بسم الله الرحمن الرحيم. أنا بشكر الدكتور علاء على الكايند introduction. I'll try to catch the extra 2 minutes بتوع علي in my talk. My talk will talk about يعني نقول ايه ترند هنسمعه خلال السنتين اللي جايين ان لم يكن بعد كده، اللي هو combination and sequencing therapies in IBD. هنبتدي في كيس دي عندها 32 سنه 32 years old female with constipation and abdominal pain for years. At year 2000 she had anal fissure. She had operation. This operation failed and caused a lot of bleeding. Then the patient have in next year a perianal abscess that had operation for that. 2 years later a colonoscopy was done and showed apoptotic ulcers in the colon and cobblestone appearance in terminal ileum, and then diagnosed as Crohn's disease. So how many years? 3 or 4 years till have been diagnosed as Crohn's disease, and at that time she received combo treatment infliximab plus immunomodulator. But 5 years later she had severe constipation that necessitated to have colonoscopy and barium, and this barium showed a lung stricture, and for that they did left hemicolectomy. 9 years later she returned back on after the surgery. She was stable on the combo treatment with infliximab, but after this 9 years she started to have worsening of the perianal situation, charge, fistula, and the patient will have at infliximab tried to be intensified every 4 weeks, no improvement. Then we measure the trough level, it was okay at 5. At that time 5 was okay for the perianal fistula. This has been learned from that now they used for the perianal fistula trough level 15. Then at 220 we shifted to ustekinumab plus azathioprine for 1 year, but the fistula did not improve. At 2021, she told us that I was better on infliximab and that charge was better. This didn't make me better. So at that time we said, okay, we may benefit from that, and use the combination, use the infliximab with the ustekinumab as a dual biologic, and for our help, God help us, that she had marked improvement and the fistula were closed, and colonoscopy showed, as you see here, complete mucosal healing. And this is a dual biologic. So what is the dual biologic? Despite the optimization of biologic therapy, we have some significant proportion of patients have secondary loss of response, or sometimes they have primary non-response. Only 40% of patients who have response, they have response to biologic therapy, maintain that remission for 1 year. And also we have some extra intestinal manifestations that may need another management. The newer biologic, which is Vido and ustekinumab, have safety profiles that appear more favorable than the combination with immunomodulators that we already used as combination biologic plus azathioprine, for example. Though that's why an emergent strategy has been used for the combination of 2 biologics, or a biologic with a small molecule, which you already have only tufasitinib for now, for those with refractory disease, and has been extended to patients also with extra intestinal manifestation that can benefit from the other drug. So for what we say dual target therapy, that we need to use 2 drugs that use different targets. So for combination means that you use 2 biologics together, but you start with 1, add it to the second. So that's called combination. What about sequencing? Sequencing means that you use a second biologic after stopping the first, but that does not mean failure. That means that the patient responded well to the first and then continue with the second. Failure means that you have failure and shift it to another one. So sequencing means good response to the first and then shift to another after stopping the one, you start with sequence. Simultaneous means that you use two biologics at the same time from the beginning. And the dual target therapy has been used if you have one drug A with drug 2 with different mechanism. This is what we call anti-TNF with immunotherapy thiopurine. Second, we have some shared combination, the patient with anti-TNF, the patient with JAK, the patient with IL-23 patients. This is shared mechanism. The third is that the use of anti-TNF or with when you use anti-integrins and S1P, which is already available now for ulcerative colitis. So this is the mechanism we have now, that you can have either additional or have a sort of overlap. And this is the drugs we have, combination biologic so far for either inflammatory bowel or others. So for combination of biologics, this is a paper from Calgary. They use here 10 patients, both males, typical females. Most of them have more than failed 4 biologics, and none used simultaneously. And the results, primary indication was either refractory disease or external manifestations. Extransinal combination, they use Vido, Adilo, Vido, infliximab, so different mechanisms. And the response was successful in most of this patient, with especially for extransinal manifestations, 100% complete resolution, and all other combinations were tolerated to astonishment for such a small population. And this paved the way that we start to use combinations. And this is another combination, the use of Vido plus tofacitinib, and also the use of cyclosporin followed by maintenance with Vido. And this could be seen in the patient with acute severe colitis, that you use cyclosporin for them, because for acute severe colitis you use either infliximab or the use of cyclosporin. But for cyclosporin you need to turn to something. So you can, after stopping of the acute setup, you can go for Vido. And this paper also used the safety and efficacy combination with calcineurin inhibitors and Vido, as you can see here. And this is published 2 years ago. Only this paper has used what we said, something which is the forbidden indication, which is the use simultaneous treatment. And this paper published the efficacy and safety of both simultaneous treatment for 2 biologics medications at the same time. And they use Vido with secukinumab, Vido with TNF, secukinumab with TNF, and all trials, double trials, we have a success rate around 50% in those difficult population. And this is the first meta-analysis for the papers used double biologic. This was 2018. It was only 3 papers. This is shifted for 9 papers in 2019. And the last one, this is still in press in clinical gastroenterology and hepatology. It will come next month. And this is the last dual biologic systemic review and meta-analysis, and they have around 279 corrected patients. They use more than 2,000, but exclude few of them because of data, insufficient thing. So they complete this and came back to us with this conclusion that adverse events, it's around 30%, clinical remission around 60%, endoscopic remission around in 30% in 1 year. And as we said, 50% extransinal manifestation, or 80% also for extransinal manifestation, and 20% for refractory disease, vice versa. And this is the medications. Only few patients have serious adverse events, and not a lot of patients that are severe. And this table showed that the patient with ulcerative colitis has a better response than Crohn's disease, and in all dual biologic papers saying the same. And they went to the conclusion that we have an attractive situation, but we still have confirmatory randomized controlled trials are needed. And in this paper in this year also, they have a proposed use of the DTT algorithm. And you can see that as a first line use infliximab plus immunotherapy or adalimumab. If they have primary failure, we went to the situation we have another mechanism, Vido or ustekinumab. But if it is secondary failure, measure the trough level, and if it is have mechanistic failure or antibodies, then whether you switch or swap or add vidofludimus for another mechanism. Also, the same thing for ulcerative colitis, and they propose that this is the already present approved drugs, and this is the already drugs that are under investigation, and they are proposing that in the next few years that we have treat to target as well as personalized medicine, and in those patients we have a sort of dynamic approach that we can have this either the combination or sequential therapy according to what the patient prognostic complications and risk of relapse, whether those patients will have combination from the beginning. And this is what they put here in their proposed, that the patient can have a monotherapy or combo, or from the beginning they have double target therapy. And for those patients, then when you have a sort of multiple options, the first option is that if you're already good with two drugs, you stop one and remain with the second, or if you feel, you switch one of the combination to have a better situation. So for conclusion, more dynamic approach to IBD patient might represent in the near future a way to enhance its efficacy, together with the discovery of new mechanism of action. The advances in personalized medicine and the implementation of new therapeutic targets and strategy are going to prevail. To prove this dynamic situation for combination and sequencing, we will have to prove first, is double target superior to monotherapy or not? Second question, is the induction of early IBD by using combination and continuing with monotherapy, or we will have to identify patients with more aggressive disease that we will have double target therapy from the beginning. Also, we have to address the situation that second target from the beginning in treat to target therapy, that we say that the patient will have target 1 and target 2 from the beginning of our situation. Lastly, we use different drugs in induction and maintenance. Whether this will be the situation, we will see. So finally, the use of dual biologic therapy in IBD is an attractive therapeutic option with different target-specific biologics now available and improved immunological understanding of IBD. There may be an opportunity to better tailor and personalize our therapy for patients. Thank you very much.